Okay. Good evening, everyone. Today's topic for this webinar is endoscopic anatomy of sinonasal and anterior skull base. And I'll be going through these following objectives. These are my objectives for today. That is a brief description of the sinonasal anatomy, a very brief discussion of the anterior skull base anatomy, a lot of discussion on sphenoid bone, and maybe a little bit on the endoscopic approaches pertaining to the skull base. So we'll go to the sinonasal anatomy straight away. So when we look at the lateral wall of the nose, we need to understand one very important point. So when we do an endoscopic sinus surgery or any surgery pertaining to the sinuses, we need to make a point that the skull base is sloping from anteroposterior. So when we push an endoscope into the nasal cavity, it should not go bang on. It should be sloping right from anteroposteriorly, supero-inferiorly. So this slope is present throughout, and that is what keeps us safe during any endoscopic procedure. So the next important structure when we go through, when we talk about the sinonasal anatomy, the first important structure that we'll always encounter is the inferior turbinate. These are scroll-like separate bones that are present on the lateral wall of the nasal cavity on either sides, right from anterior to posterior. The two important things that we need to keep in mind with respect to the inferior turbinate is, one is the opening of the nasolacrimal duct, which falls in the inferior meatus, and the opening of the eustachian tube, which is posteriorly. So these two important structures are very closely correlated to the inferior turbinate. So we go slightly superiorly, we come across the middle turbinate. This is about endoscopic procedure that was done. You can see the middle turbinate right here. So when we talk about the agar nasi, it is the most anterior ethmoidal air cell, right? So it forms a significant bulge just anterosuperior to the middle turbinate. So this cell is always single. That is something that we need to keep in mind. It is one of the pathways to the frontal sinus. So if we remove the agar nasi, we can enter the frontal sinus pretty easily if we know the anatomy well. There are a lot of anatomical variations with respect to the agar nasi. So if it is too large, then it may block the frontal recess drainage pathway. It can be enlarged anteriorly, and it can impinge on the lacrimal bone and can obstruct the nasolacrimal pathway as well. So we need to keep in mind that agar nasi is one single air cell that is present just anterosuperior to the middle turbinate. So just behind that, we have something known as a frontal sinus drainage pathway. You can see a characteristic picture of a patient here with an open frontal sinus. There's an illumination test that was done in patient to confirm the presence of the frontal sinus. So when we talk about the frontal sinus drainage pathway, you'd look at a three-dimensional picture. The reason being, there are a lot of anatomical variations that can have significant impact on the frontal sinus drainage. We have cells from anterior, that is agar nasi, and that is one single air cell. Then as per Kuhn's classification, there can be single or multiple air cells above the agar nasi. So Kuhn's 1 is one cell above, Kuhn's 2 is there are two cells above the agar nasi. Kuhn's 3 is there's a cell extending into the frontal recess, less than 50% involvement of the frontal. And then there's a Kuhn's 4 where the cell is completely in the frontal sinus. And then from the posterior aspect, in front of the bulla, there can be cells. These are known as frontal bulla cells extending all the way up. There can be one or multiple cells present within the bulla. So this can significantly impact the frontal sinus drainage pathway. It can either be medial, lateral, anterior, posterior, based on the arrangement of cells around the frontal sinus, right? So we need to study the scans extremely carefully when we look at the frontal sinus drainage pathway, right? So key points, we follow the agar nasi or the Bulla ethmoidalis, back up, and we need to reconstruct the drainage pathway based on Kuhn's classification. And we always need to keep in mind that the anterior ethmoid artery lies in the floor of the drainage pathway, that is the roof of the Bulla ethmoidalis posteriorly. So we need to be careful of this artery that is present in the frontal sinus drainage pathway. Coming to the middle turbinate, it's got three important attachments. The first two attachments are to the skull base, that is, one is in the sagittal plane, second is in the coronal plane, third one is in the axial plane. So we have three attachments of the middle turbinate. Two of them are in the closely relation to the skull base, along with the lamina papyracea, and the axial attachment is closely related to inferior turbinate attachment or to the perpendicular plate of the palatine bone. So these are the attachments of the middle turbinate which we need to understand. The second attachment of the middle turbinate, which is in the coronal plane, is also known as the ground lamella of the middle turbinate, which helps us to differentiate anterior ethmoidal air cells from the posterior ethmoidal air cells. This is a three-dimensional picture of the middle turbinate taken from Stambo's book. So there are multiple variations that can impact the drainage of the anterior group of sinuses. You can see one variation right here that is known as the concabulosa, that is pneumatization of the middle turbinate. There can be appearance of a double turbinate, and so on and so forth, right? There can be hypoplastic turbinate as well. Okay, so when we do an endoscopic sinus surgery, there are always four lamellae from anterior to posterior, which we have to bulldoze through on the way, starting from the uncinate process, the bulla ethmoidalis, the uncinate process, the bulla ethmoidalis, the ground lamella, and finally the posterior group of cells along with into the sphenoid ostium. So these four lamella are extremely important to us. Well, the key points that we need to consider are, whenever we do it, whenever we bulldoze them, you always remember that you have to go lateral to medial and superior to inferior to limit the damage to important structures. And each lamella needs to be taken down systematically with respect to endoscopic sinus surgery, and always look out for anatomical variations. So these are the four lamellae one by one. First one, the uncinate, the second one being the bulla ethmoidalis, the third one being the ground lamella of the middle turbinate, and the fourth one being the anterior wall of the sphenoid. So four lamellae taken down systematically. So we've done with a few important structures, that being the inferior turbinate. We finished off with the frontal recess drainage path, frontal sinus drainage path. We finished on middle turbinate, and now we are coming to the uncinate process. The uncinate process plays a significant role in the frontal drainage pathway, mainly because of the fact that of its attachment. It can have three variations in attachment. One is to the skull base, second one to the middle turbinate, and the third one to the lamina papyracea. So this will help us understand the frontal sinus drainage, whether it's anterior or posterior, or medial or lateral, to this attachment. So we all right. So inferiorly it's attached to middle turbinate, as we call it, right? So that's the uncinate process. The attachments of the uncinate process are clearly seen. How we can do that is, we can push in a ball probe and just tug on it and find out the attachment of the uncinate process. So when you look at the infundibulum and the maxillary ostium, so once the uncinate process is taken down, you can observe the natural maxillary ostium, and you can differentiate it from an accessory ostium in a way that the accessory ostium is present even when the uncinate process is not taken down. So this is the accessory ostium, which is identified without doing an uncinectomy. The next important structure that we'll come across is the bulla ethmoidalis. That's the anterior group of cells. We always stay medial to the opening of the maxillary sinus. The bulla ethmoidalis is present. It's an anterior ethmoid group of cell. So what we need to keep in mind is, we need to identify the plane of the maxillary ostium and stay medial to it while doing an endoscopic sinus surgery. And always identify the anatomical variations with respect to it. So when we look at bulla ethmoidalis, so considering this being the skull base and this being the ground lamella of the middle turbinate, the bulla ethmoidalis, and that's a frontal recess or the frontal sinus drainage pathway, bulla ethmoidalis is located right there. Okay, so when we look at the variations, or you can say normal variations that can be present, they can be clefts around the bulla, right? One is known as a suprabullar recess, the other one is known as a retrobullar recess. So both these recesses, when present together, this conforms itself to this thing called as the lateral sinus of Grunwald. So this is known as the lateral sinus of Grunwald, which may be present when both the recesses are present together. So how do we identify the posterior ethmoids? Once you've gone beyond the ground lamella of the middle turbinate, you come into the posterior ethmoids. There are multiple posterior ethmoid air cells. How do we identify them? It's all based on the curvature, right? The sphenoid wall is convex, the posterior ethmoid wall is concave. That is how we identify and help in differentiating between the posterior ethmoids and the sphenoids. And we need to look at the posterior ethmoid relations very carefully because the optic nerve and the orbit are in extremely close relation to the posterior ethmoid group of air cells in the lateral wall. So that is why superior to inferior, lateral to medial. So that is how we go about doing an endoscopic approach. So CT correlation is is absolutely essential to identify all the cells because there is a cell called as the onodi cell. It's a posterior ethmoidal group of air cell which shares a common wall with the optic nerve, although it occurs in close relation to the sphenoid sinus. Similarly, if you look at anterior ethmoidal group of air cells, there's a cell called as Heller cell, which is an intraorbital air cell. So these cells are extremely important to be taken down as far as endoscopic surgery is concerned. Sphenoid sinus in the sphenoid model recess, you can see the ostium there, you can see the onodi cell right there. Okay. So this highlights the importance of the sphenoid sinus. We'll talk about it a little later during the presentation. So that is the sphenoid sinus anatomy. You can see that's the rostrum of the sphenoid. The septum has been taken down. You can see the rostrum of the sphenoid. You can see the openings, the ostia right there. These are the ostia and these are the sinuses. And you can see the rest of the structures. So we need to keep in mind that the sphenoid ostium is far down medially and inferiorly. So only if we take down the superior turbinate, you will be able to identify when you go from lateral to medial approach, you will be able to identify the sphenoid ostium. Right. So what is anterior skull base? We've spoken about the endoscopic sinus anatomy. You have the sphenoid sinus, which is in very close relation to important structures. Let me just project it for you. Okay. So you can have the internal carotid artery, you can have the optic nerve, the opticocarotic recess, medial and lateral opticocarotic recess, and then you can have the sella in the lower in the segment of the posterior wall of the sphenoid, along with cavernous sinuses in very close relation to the posterior wall, right? So that is why the sphenoid sinus is extremely important to us, right? So what is anterior skull base? It basically forms the floor of the anterior cranial fossa. Although you have various approaches that you can do by approaching through the anterior skull base, but the anterior skull base for all practical purposes is the floor of the anterior cranial fossa, which contains of a midline structure and a lateral structure. So it roofs over the orbit. Okay, so if you look at this image, it roofs over the orbit and the ethmoidal air cell system. And the when you talk about the boundaries anatomically, it is anteriorly, it's related to the posterior wall of the frontal sinus. Posteriorly, it is the lesser wing of the sphenoid along with the anterior clinoid processes. And laterally, it is the orbital plate of the frontal bone. So that is it about anterior skull base. So what are the bones that constitute it? There are three important bones. You have the frontal, the ethmoid, and the sphenoid bone. Right. When you look at the frontal bone, the orbital plate of the frontal bone is extremely important to us as far as the anterior cranial fossa is concerned. It's got two important foramina, which transmit the anterior and the posterior ethmoidal arteries, which are branches of the ophthalmic artery, which arise from the internal carotid system. So how do we identify these structures is we take a distance from the lacrimal crest and you will be able to identify the these arteries. So 24 millimeters, 12 millimeters, and eventually the 6 millimeter one is from the posterior ethmoid is the optic. So that is the formula to find out the relation of the lacrimal crest to the foramina. So when we look at the ethmoid bone, which forms a very important part of the anterior skull base, it's got a midline crista galli and a perpendicular plate of the ethmoid, and you've got a horizontal attachment that is the olfactory plate. The rest of it is all ethmoidal bulla and the ethmoidal group of sinuses. But what is important to us is right here. Okay, so this articulates with the orbital plate of the frontal bone, forms the fovea ethmoidalis. So the midline, you have the olfactory plate, then you have the lateral lamella, the vertical component. The lateral lamella articulates with the orbital plate of the frontal bone, which forms the fovea ethmoidalis, which is one of the weakest structures during endoscopic sinus surgery, and it can lead to a CSF leak. So with respect to that, Kiro has classified it into three components: Kiros 1, Kiros 2, and Kiros 3, which is dependent on the depth of the skull base. 1 to 3 millimeters of the fovea or the lateral lamella is Kiros 1. 4 to 7, 1 to 3 millimeters, 4 to 7, and more than 7 millimeters is Kiros 3. So as you go higher along the depth, more are the chances of injury. So that's the anterior ethmoid artery lying snugly on the skull base. What we need to keep in mind is it can also hang down from a mesentery and cause problems. That is when it is more prone to injury. Sphenoid bone is regarded as a workhorse of endoscopic sinus surgery, endoscopic skull base surgery, because through the sphenoid you can approach a lot of structures. So when we look at the sphenoid, it's got different parts. You have the lesser wing of the sphenoid, there's a greater wing of the sphenoid, and the pterygoid processes along with the body. So the lesser wing of the sphenoid is in extremely close relation to the optic canal and the superior orbital fissure. And if you look at it, the superior aspect articulates. It articulates with the olfactory plate, and it forms a very important component. And this flat structure is known as the plenum sphenoidale. So when we go lower down, you have the greater wing of the sphenoid, which is in very close relation to the foramen ovale and the foramen spinosum, the foramen rotundum, and that is the importance of the greater wing of the sphenoid. So when we look at the pterygoids are in close relation. If you look at the pterygoid, it's in very close relation to the foramen lacetum. That is where it's closely related to the internal carotid artery as well. And we need to understand that there are muscles attached to the lateral plate, right? So that's about the sphenoid. And the sphenoid body obviously houses the sphenoid sinuses. This is basically the pneumatization of the sphenoid sinuses, that is pre-cellular, cellular, and post-cellular pneumatization. So when we look at this is within the sphenoid sinus, I've already sort of given an overview. So you have the plenum sphenoidale right there. The junction of the plenum sphenoidale with the cellular area is known as the tuberculum cellae, and lower down we have the clivus. And you can see the middle clinoid right there. You can have the carotid, the optic nerve, the medial and the lateral OCRs right there. So apart from that, there are a lot of foramina and crests that are present in the anterior skull base, which are of importance to us, right? Starting from the frontal crest. If you look at the frontal crest, it gives attachment to the falx cerebri. A little posterior to it is a small foramen that is known as the foramen cecum, where an emissary vein passes from the nasal cavity into the superior sagittal sinus. The crista galli is closely related to the falx cerebri and attaches it. The cribriform plate of the ethmoid is responsible for transferring the olfactory filaments from the nose into the cranial cavity. The superior orbital fissure transmits the 346, that's the cranial nerves 346, along with the lacrimal, frontal, and the nasociliary nerves. And the inferior orbital fissure is in very, very close relation where it transmits the V2 along with the inferior orbital artery and vein, right? So the optic canal transmits the optic nerve, the anterior and the posterior ethmoid foramina. You have the optic foramina right there. Superior and the inferior orbital fissure will be right inside. And finally, you have the anterior and posterior ethmoid foramina, which transmit the anterior and the posterior ethmoid arteries. So when we take a cross section, rather, you destroy everything, and what is left of the skull base is this anterior ethmoid artery, middle ethmoid artery may sometimes be present, not always, and the posterior ethmoid artery. So in the sagittal plane, so when we look at the endoscopic skull base, I mentioned that the sphenoid sinus is known as the workhorse. So why is it the workhorse? Because you reach the sphenoid sinus and you can bifurcate in two directions. You can either go laterally and approach a lot of other structures, and you go right bang on and you can access a lot of structures when you go bang on. That is not the crux of today's discussion. However, I've just mentioned the approaches through which anterior skull base can be made very useful. That is the transfrontal approach goes to the frontal bone, the cribriform approach goes to the cribriform plate, the transplanum to the plenum sphenoidale. Transsphenoid, you go open up the sphenoid and go posterior to get access to the pituitary and other structures. Then you have the transclival approach. You go through the clivus into the middle cranial fossa, and you have the transodontide approach. When you go through that, you enter the posterior cranial fossa. Not only that, in the coronal plane also there are multiple approaches. You go through the orbit, it becomes supra and transorbital depending on where you go through it. In the middle, you have the petrous apex, the cavernous, the Meckel's cave, the transpterygoid infratemporal fossa, very closely related to the pterygoid plates. And then you have posterior, that is transcondylar infrapetrous, and the parapharyngeal space approaches. So there are a wide variety of approaches to access wide area, a lot of areas which inhabit a lot of pathologies. So these skull-based approaches can be employed in the treatment of various skull-based disorders. Thank you for your attention.